Hello, this is Mirrakhimov speaking. I'm one of the cardiac anesthesiologists at the University of Kentucky, and today we'll be talking about non-catecholamine vasopressors and inotropes. I have no conflict of interest to report. Please take a moment to review the disclaimer for this presentation. So we'll be talking about vasopressin, angiotensin II, methylene blue, hydroxycobalamin, calcium, and milrinone. And the goal of the discussion is to review pharmacology, relevant receptors, dosing, and side effects. So vasopressin, also known as ADH or antidiuretic hormone, it is produced in supraoptic and paraventricular nuclei of hypothalamus. Then it is transported and stored in the posterior pituitary. Hypovolemia, increased blood osmolality, stress, and certain medications can increase ADH secretion and release. On the right part of the screen, you see an image representing the relationship between different nuclei of hypothalamus and the pituitary gland. So what about receptors to vasopressin? There are several ones which are important for us to know. Let's talk about V1A first. They are present in the vascular, liver, adrenal glands, and uterus. Activation leads to increased vascular tone, glycogen degradation, increased secretion of cortisol, aldosterone, and norepinephrine, as well as uterine contraction. Next is V1B receptors, which are located in the pituitary gland and the pancreas, and activation leads to ACTH secretion and glucagon release. V2 receptors are located in the collecting ducts, and the activation leads to increased water absorption. Also, V2 receptors are present in the vascular endothelium, and the activation leads to increased release of von Willebrand factor and coagulation factor 8, as well as vasodilation. As you can see, V1A receptors and V1B receptors can modulate blood pressure indirectly through increased secretion of ACTH and cortisol, aldosterone, and norepinephrine. On this image here, you see the detailed mechanism by which vasopressin or ADH leads to water reabsorption via V2 receptors in the principal cells of collecting ducts. Let's take a moment to review this image. So what about the indications for vasopressin? It can be used in the management of distributive shock as a second-line agent after norepinephrine, such as septic shock and vasoplegia syndrome after cardiac surgery. Organ donor management is another venue for its use, especially in donors who have hypertension and diabetes insipidus. Vasopressin is associated with no to minimal increase in pulmonary vascular resistance compared to catecholaminanergic medications such as norepinephrine, for example. This can be a helpful feature, especially in patients who have elevated pulmonary blood pressure. Of note, vasopressin is not an inotrope and does not improve cardiac contractility and cardiac output. The typical infusion dose of vasopressin is from 0.01 to 0.06 units per minute. Doses which are higher than 0.04 units per minute are associated with higher rates of ischemic complications such as mesenteric ischemia and coronary ischemia. Avoid giving this medication through a peripheral IV due to concerns of extravasation and tissue injury. Remember that there is no direct antidote against vasopressin extravasation. It is recommended to wean this medication slowly to avoid rebound hypotension. Of note, sometimes this medication can be given as a bolus, especially in the dire circumstances of the operating room when the patient is hypotensive. Just a factoid, 1 unit bolus is equal to approximately 25 minutes of 0.04 units per minute infusion of vasopressin. Something to keep in mind. If you remember that oxytocin is also produced in the hypothalamus and then stored in the posterior pituitary. On a chemical level, oxytocin is quite similar to vasopressin and ADH. That is why sometimes it can lead to antidiuretic effects. And vasopressin, for example, can act as a uterotonic. And obviously, the antidiuretic effect of oxytocin is quite weak compared to ADH, and the vice versa uterotonic effect of vasopressin is relatively weak compared to oxytocin. Syndrome of inappropriate ADH release, or SIDH, is not directly related to the topic of our discussion today, but I think it is important for us to quickly review it because it's a highly testable topic. Factors such as surgery, CNS disease, malignancy such as small cell lung cancer, pulmonary disease such as pneumonia or pneumothorax, and medications such as carbamazepine and selective serotonin reuptake inhibitors can all lead to SIDH. Clinically, it is present in patients who have euvolemic hyponatremia associated with low serum osmolality, increased urine sodium, and increased urine osmolality. Let's go through a question. A medical student is working with you in the operating room, and your patient has CKD, and the decision is made to administer desmopressin to help with hemostasis. You give 0.3 micrograms per kilogram dose of desmopressin over 1 minute, and note that the mean arterial pressure decreased from 72 to 64. Then your medical student asks you, why did this patient develop hypertension to desmopressin? If so, how does it cause the hypertension, whereas vasopressin tends to increase the blood pressure? So desmopressin is a selective V2 receptor agonist. Its specificity for V2 receptors versus V1 receptor is approximately 3,000 to 1. If you remember from the previous slide where we discussed different receptors of vasopressin, V2 receptor is associated with vasodilation. That is also why desmopressin can be used in patients who have von Willebrand disease and mild cases of hemophilia A, because it leads to increased release of von Willebrand factor and factor VIII from the endothelial cells. The adverse effects of vasopressin include ischemia, hyponatremia due to its antidiuretic hormone properties, and extravasation injury. That is why it's highly recommended to give vasopressin through a working central venous catheter. And again, remember there is no antidote for vasopressin-related extravasation injury. Let's continue talking about renin and renin-angiotensin-aldosterone system, or RAS. This system plays an important role in blood pressure regulation and volume regulation. Renin is released from the afferent arterial cells called juxtaglomerular cells. Certain factors such as low blood pressure, increased sympathetic activity, and low sodium are potent stimuli for renin release and secretion. Let's quickly review the metabolism of angiotensin. Renin converts angiotensinogen into angiotensin 1, which then can enter either classical RAS pathway or non-classical RAS pathway. Angiotensin converting enzyme, or ACE, produces angiotensin 2 from angiotensin 1. Angiotensin 2 can act on several receptors, such as angiotensin 2 receptor type 1 and angiotensin 2 receptor type 2. Angiotensin receptor type 1 is the main target for angiotensin 2 medication, and it leads to increased vascular tone. Please take a moment to review this slide because there are way more details which are potentially important for us to understand. Again, two main receptors, angiotensin 2 receptor type 1 and receptor type 2. Receptor type 1 is located in the vascular smooth muscle, hypothalamus, and adrenal gland. Activation of this receptor leads to increased vascular tone and vasopressin release and aldosterone release. Inactivation of type 2 receptor, which is predominantly located in the vascular smooth muscle, actually leads here to vasodilation. Of note, angiotensin 2 can lead to improved blood pressure control, not only directly through its mechanism on the vascular wall, but also via vasopressin release and aldosterone release. The indication for angiotensin 2 include refractory septic shock, refractory vasoplegia, and may have some superior performance in patients who have coexistent acute kidney injury. Again, angiotensin II is a pure vasopressor and has no inotropic properties. When given as a medication, angiotensin II undergoes very rapid metabolism by aminopeptidases and angiotensin converting enzyme type 2 into angiotensin III and angiotensin 1,7. Angiotensin III actually mediates most of the vasopressor response of this medication, and there is no need to adjust the dosing for renal or liver function. On this slide, you see recommended starting dose and the maximum dose of angiotensin II. Adverse reactions to angiotensin II include ischemic events such as mesenteric ischemia, coronary ischemia, thrombotic events, and thrombocytopenia. Of note, angiotensin II is typically used in patients who are extremely ill and are at much higher risk for those adverse reactions even in the absence of angiotensin II. Nitric oxide, or NO, is produced by endothelial cells and acts as a vasodilator, antiaggregant, and antiatherogenic molecule. Its production may be upregulated in states of distributive shock, such as septic shock and vasoplegia state after cardiac surgery. The precursor for nitric oxide is amino acid arginine. So let's talk about methylene blue first. It is a water-soluble dye, and it inhibits nitric oxide synthase and soluble guanylate cyclase, leading to decreased amount of nitric oxide and nitric oxide mediated signaling. Of note, it was initially used or tried as anti-malaria medication many years ago. Indications for methylene blue use include methylhemoglobinemia, refractory vasoplegia after cardiac surgery, and refractory septic shock. So typically, methylene blue is given as a bolus 1 to 2 milligrams per kilogram over approximately 15 minutes and usually then started as an infusion. Consider dose reduction in patients who have severe liver or kidney disease. Let's talk about the side effects to methylene blue. Serotonin syndrome via MAO or monoamine oxidase enzyme inhibition. Remember that methylene blue blocks nitric oxide synthesis, and nitric oxide is a very important pulmonary vasodilator. Thus, methylene blue sometimes can lead to pulmonary vasoconstriction and hypoxia. It can also lead to spurious oxygen saturation, extravasation injury, hemodialysis machine malfunction, and skin and urine discoloration. Interesting to note that hemolysis and even methylhemoglobinemia can be a side effect when methylene blue is used in patients who have glucose 6-phosphate dehydrogenase deficiency, or G6PD. On the left part of the screen, you see a pictorial explaining the mechanism of such association. Please take a moment to review this slide. Next, we'll talk about hydroxycobalamin, which is a vitamin B12 precursor. The mechanism of action of hydroxycobalamin includes NO scavenging, inhibition of nitric oxide synthase, and guanylate cyclase. In addition to that, it blocks hydrogen sulfide, or H2S, which is also believed to play a role in vasoplegia and decreased vascular tone. The indications for hydroxycobalamin use include refractory septic shock, refractory vasoplegia after cardiac surgery, and cyanide toxicity. The typical dose of hydroxycobalamin is 5 mg given IV over approximately 15 minutes. The side effects include hemodialysis machine malfunction, angioedema and anaphylaxis, spurious laboratory results, acute kidney injury, and calcium oxalate kidney stones or nephrolithiasis. Also, hydroxycobalamin can lead to red urine discoloration. Next, we'll talk about intravenous calcium. Intravenous calcium increases the vascular smooth muscle tone and cardiac myocyte contraction. So it's a vasopressor and a nitrotrope. Also, recall that calcium is known as coagulation factor 4 and plays an important role in coagulation cascade. And on the right side of the screen, you see the biochemical pathways through which calcium exert its effect on the vascular smooth muscle tone and the cardiac contractility. Some of the indications for IV calcium administration include refractory distributive shock, decreased cardiac contractility, beta blocker, and calcium channel blocker toxicity. Consider giving calcium if especially your patient is hypocalcemic, has concomitant hyperkalemia, or is receiving blood product transfusion. What about the available calcium formulation we can use? So first let's talk about calcium gluconate. The teaching was that calcium gluconate needs to be activated in the liver first to release calcium into the bloodstream. The literature and research actually doesn't support that. It is less likely to cause tissue extravasation, and the typical dose is 1 to 3 grams diluted in about 50 cc's of crystalloid, such as, for example, normal saline. Calcium chloride has at least 3 times more calcium compared to gluconate formulation, but has much higher risk of extravasation injury. The typical dose is 0.5 to 1 milligram administered over approximately 15 minutes. Administration via central line is preferred for calcium chloride, again because of the risk of extravasation injury. Next, we'll talk about milrinone. It blocks the enzyme called phosphodiesterase 3 or PDE3. On the left part of the screen, you see that inhibition of PDE3 enzyme leads to accumulation of cyclic AMP or adenosine monophosphate and leads to improved cardiac contractility. On the right part of the screen, you see that phosphodiesterase 3 inhibition leads to smooth muscle relaxation in the vascular wall, explaining why patients who receive milrinone often get hypotensive. Let's compare effects of milrinone and dobutamine. Just to remind ourselves, dobutamine is catecholaminergic inotrope. Milrinone is less likely to increase heart rate compared to dobutamine. Milrinone has slightly more pronounced effect on the pulmonary vascular resistance, or tends to decrease PVR slightly more than dobutamine. Onset of action of dobutamine is much faster than milrinone, and the duration of action for milrinone is much longer than for dobutamine. The excretion of milrinone is via kidneys, and patients who have kidney dysfunction can accumulate this medication and lead to prolonged duration of action. The metabolism of dobutamine is via COMT enzyme and methyl enzyme, which is catecholamine or methyltransferase and monoamine oxidase enzymes. The indications for milrinone include post-cardiotomy shock, both left ventricular and right ventricular, cardiogenic shock, especially with coexistent pulmonary hypertension. Also, milrinone is quite often used in management of chronic end-stage heart failure patients. Milrinone can be administered as an infusion, as a bolus, and as nebulized milrinone. Higher doses are associated with systemic hypertension. Bolus doses sometimes can be considered to achieve steady state faster, but again, they're more likely to cause hypotension. Of note, it is believed that nebulized milrinone has very little effect on systemic blood pressure and may be preferred for this reason. Some of the side effects of milrinone include systemic hypotension. It has a potential to trigger myocardial ischemia due to increased demand from positive inotropic effects, and sometimes can have prolonged duration, which may be a problem, especially in patients who have kidney dysfunction. So in summary, non-catecholamine pressors and inotropes are effective rescue therapies. Unfortunately, this may not always result in a better mortality. Since these medications are not first-line agents, administration via central line is essential to minimize the risk of extravasation injury And again, there is no antidote for those medications in terms of extravasation injury compared, for example, to norepinephrine or phenylephrine. Some of these medications may lead to spurious laboratory data. Milrinone, which is an inotrope and antidepressor, plays an essential role in the cardiac surgery world. Unfortunately, it is associated with systemic hypertension, sometimes requiring a concomitant vasopressor administration. This concludes this presentation. I want to thank you for your attention. If you have any questions regarding this presentation, please email me to the address presented on this slide. I wish you all the best and good luck.